So, dear colleagues, I've been told that I'm talking and I have the privilege to talk to a global audience. So, again, good morning, good afternoon, and even good evening to you all. And it's my pleasure to talk about a topic which, the more I dive into, the more confused I'm actually about. And I would like to share some of the reasons that confuse me, but also trying to be productive in my confusion, in our joint confusion, and think again and discuss together what we can do in terms of research to better understand neonatal temperature regulation, but also management. So basically, the reason for my interest in this topic is obviously I'm a clinically engaged neonatologist. So obviously, I care for sick and premature infants every day. But also, I've had the privilege to work together with a very distinct and respected group of people working on a joint European standard of care for newborn health about the topic of avoiding hypo and hypothermia during the golden hour after birth. And this actually was the main driver for me diving more and more into this topic. And I'm sure that you have read the agenda for today, and I've structured it like that. First and foremost, I would again like to remind every one of us how important it is to keep babies warm after birth. And it's essentially important to improve the survival. Then, of course, we'd always think about, as clinicians, what we can actually do in the delivery room during postnatal stabilization to maintain normothermia in our smallest and most immature babies. And then I would like to address some of the knowledge gaps, and I've also added one challenge in neonatal temperature management. Before, probably like more of a conclusion or a summary, I would like to define at least some key areas that I see for patient-centered research on neonatal thermoregulation. And I will try to keep this topic and this presentation very specific on the concept of the first hour after birth, which we all know has been coined the golden hour after birth. So starting with the first aspect, and I think that's not new to any one of you, we know that the fetal body temperature is closely related and linked to maternal body temperature. And we know that, like, for example, from studies like this one in animals, but we also know that from fetal studies in human beings, that mother and baby are closely interlinked also in regards to thermoregulation before birth. And then, of course, there's always the question of how is thermogenesis being started and begun after birth. So we know in utero, and that makes physiologically based a lot of sense, there's some inhibitors of thermogenesis in utero, like prostaglandin E2 and adenosine. There's also the low fetal PaO2, which is an inhibitor of thermogenesis. So to get thermogenesis started after birth, the baby actually needs to be separated from placenta and from those inhibitors of lipolysis. Of course, increased oxygenation is a driver and the catalyst of everything. And of course, there will always be some sort of stimulation of cutaneous cold receptors. And you see on the right side in this figure how closely related non-shivering thermogenesis and an increase in PaO2 after birth is. So there's a clear relationship between us supporting the baby in oxygenation and also driving non-shivering thermogenesis after birth. And of course, we know, and it hasn't been a lot of new knowledge actually on these main mechanisms of postnatal thermoregulation. We know that in every baby that is being born, there's some sort of vasoconstriction, which makes, again, a lot of sense because heat should actually stay next to the core of the baby's body. And we also know about this rather potent mechanism of non-thermic thermogenesis due to the brown adipose tissue, which is, of course, a fascinating concept in most infants who are at least born term. Yeah, and there's to some degree, and we can't really estimate it correctly, there will be some degree of shivering thermogenesis, which will contribute to postnatal thermoregulation, but we are pretty sure and can be pretty sure that vasoconstriction and non-shivering thermogenesis are probably the two main mechanisms that the babies use to keep their temperature stable or normal after birth. So the concept of non-shivering thermogenesis has been studied rather extensively within the last decades, and these brown adipose tissues storages that are prevalent, either rather superficial, but also next to deep organs. They are very important. But of course, we also primarily think about what is about those very immature, light for date babies, yeah, which we know have just little storage of adipose brown tissue next to all the other issues that they have when we think about their inability to keep themselves stable in regards to temperature regulation. And I think this sentence really clearly tells us and summarizes the main issues that most babies, especially those born prematurely or very sick, are confronted with. So we know there is heat loss after birth, yeah, and we know about these different physiological reasons why babies are not very effective in keeping their body temperature stable, yeah. So in essence, they're not able to generate heat by themselves on a regular and consistent basis. We know about the large surface of the head, for example, where a lot of heat is being lost. We also know about the immature skin barrier that is a main driver, not only to water fluid loss, but also, of course, in conjunction with that, also loss of heat after birth. So these are the factors, or at least some of the factors that contribute to the significant heat loss after birth. And I've shown this study, which is an old one from 1972, in my last webinar as well, because it so clearly and nicely, but also dangerously shows and summarizes what happens to babies if we don't properly care for them after birth. Because in this study, different interventions were studied in regard to thermoregulation after birth. And you can easily see when we look at this group at the bottom of the graph, and this is the first 30 minutes after babies were born, yeah, we can clearly see if babies are kept wet, so which means not being dried after birth, at room air, so no radiant heater, no additional heat sources, they will probably lose around 2 degrees of Celsius in rectal or core body temperature within 30 minutes after birth. But even if we dry them, and even if we add additional heat, for example, by using a radiant heater, babies may lose some of the temperature. Yeah? And in this study, it was at least 0.7 degrees of Celsius, which I think we all agree is still a significant heat loss for the first 30 minutes after birth. And for a very long time, we actually knew about the association between postnatal hypothermia and less favorable outcome. Yeah. And again, I picked an older study, and I think it was from 1957, where actually there were two sets of humidity compared to one each other. So it was rather large cohorts of babies. You see here 160 versus 164, all of them weighing around 1,500 grams. Interestingly, actually, the gestational age is not being provided in this study. And what the colleagues actually did, they compared two relative humidities. You see 30 to 60% in comparison to 80 to 90% in incubators during the first days after birth. And you can easily see that the mean body temperature in both cohorts, although they were kept at constant temperatures in those incubators, yeah, both groups at mean were hypothermic during the first couple of days. Yeah, and you can see that's rather profound hypothermia when we compare 33.6 to 34.2 degrees of Celsius. But even more worrying actually is that the mortality rate was significant in both groups. And not very surprisingly, in the groups with the lower relative humidity and the lower mean body temperature, the death rate or standardized mortality rate was even higher. And you can also appreciate how high in general the mortality rate is, but we also have to acknowledge that this study is almost 70 years old. But anyways, I think it clearly shows the dramatic and significantly negative impact of postnatal hypothermia and hypothermia during the first couple of days. Coming to newer data, I would say, and in this study by Liu and colleagues, there was an inclusion of almost 10,000 preterm neonates below 33 weeks of gestation. And what they actually studied was the association between admission hypothermia and a composite outcome consisting of mortality or significant morbidities like high-grade IVH or PVL, high-grade ROP, neck of grade 2 or higher, BPT, or nosocomial infection. And I think you can easily see on the two figures on the left that in the upper graph that there's a clear disadvantage of those babies who are born more immature in terms of the rate of admission hypothermia in comparison to those preterm neonates who were born at a more mature age. And again, on the lower graph, we can also see, and that is not surprising to any one of us, that the birth weight below 1,000 gram was clearly an added disadvantage in comparison to those preterm babies who had a birth weight of 1,000 to 1,500 grams. And what we also saw in this study was that in this large cohort of babies, and I'm sure that they were treated very properly, more than 1/3 was hypothermic at admission. And we also always must acknowledge that there's also a too much of interventions, because 7% of those babies were actually hyperthermic with a body temperature of about 37.5 degrees of Celsius at admission to the neonatal intensive care unit. And when this composite outcome of mortality or severe morbidity was actually plotted against admission temperature, we can clearly see and appreciate this almost U-shaped curve. And just based on multivariate analysis, the composite outcome had the lowest incidence at an admission temperature of 6.8 degrees of Celsius. But when we think about a range of 1 degree of Celsius below normal temperature, which would mean 35.5 degrees of Celsius, and about the range of 1 degree of Celsius above normal temperature, which would be, of course, 38.5 degrees of Celsius, we can clearly see, again, 1 degree of Celsius below normal temperature, a composite outcome risk of or rate of 40%. And when temperatures were elevated, this risk or incidence of a negative outcome was even higher, around 50% of those babies in this large cohort studied here. And again, this is not new to any one of you, but I think it also gives us a clear impression of why we have joined each other here to think about this very important topic. And again, in this systematic review and meta-analysis, we clearly are being shown that admission hypothermia is actually associated with a significantly elevated risk of mortality, an elevated risk of suffering from IVH, from BPD, from sepsis, and also from ROP. So I think data is sufficient to clearly illustrate this association between postnatal hypothermia and a negative outcome for our most vulnerable and smallest patients. But again, as clinicians, we always think about what can we do to keep babies warm after birth? What can we do to prevent hypo and even hyperthermia? And fortunately, there have been a lot of studies within the last couple of years, especially, and also some meta-analysis who help us guiding what we do during postnatal care and in delivery room setting. And again, that's something that probably many of you have already embraced as their standard treatment to keep babies warm after birth, because in this systematic review and network meta-analysis, including more than 3,500 preterm neonates and comparing 9 different interventions and different bundles of interventions, it was clearly shown that using a plastic bag or using a plastic wrap together with heated humidified respiratory gases significantly lessens or reduces the risk of suffering from major brain injury, and using a plastic bag or wrap with a plastic cap significantly decreases the risk of dying within the neonatal setting. So again, this probably supports what we do as a routine in many settings, but fortunately, and I'm pretty sure that is important. We all appreciate that it's always different bundles of interventions that are actually very important. I've chosen this study actually because it summarizes another cohort which is probably studied to a lesser degree, and those are moderate to late preterm neonates, because we know that those associations that I showed you previously for the more immature babies between postnatal hypothermia and a less favorable outcome, these associations are also predominant for the moderate and late preterm infant. And what we can see here is actually a quality improvement project, including more than 560 inborn moderate and late preterm neonates. You see that their mean gestational age was around 34 weeks of gestation, with a rather high mean birth weight of around 2,300 grams. And there were actually two periods in this quality improvement project where different interventions were actually set. And the first one was a very, very, I would say, simple, but I've talked to a lot of colleagues who tell me that it's difficult intervention to actually get through, because the first thing that the colleagues did in their quality improvement project was that they increased the temperatures in their delivery room when there was the anticipation of a preterm birth. And you see, what they recommended was 70 degrees of Fahrenheit, which is around 21 degrees of Celsius. So not even very high temperatures. Yeah. They also coupled it with specific notes in their online system, advising colleagues who were actually doing notes on the patient to keep the baby warm and informing them about certain interventions that would help them keeping the preterm neonate warm after birth. And in the second period, what they actually did is they changed the recommendation of the ambient room temperature of 70 degrees of Fahrenheit to a restricted one. And they also added a thermal mattress to keep those moderate and late preterm neonates warm after birth. And you can clearly see in the dark blue line and graph here that there was an up and down, which we see very often, I think, during our clinical practice. But at the end, coupling all of these quality improvement intervention as a bundle, you clearly see that the aim that these colleagues set, which was lowering the admission hypothermia rate below 10%, was actually clearly met. So what we can appreciate from this study, I would think, is that there's different interventions that we have to ensure that will help us keeping our babies warm after birth. And very interesting, I think that is something that should never be lost, actually, because those were obviously cardiorespiratorily stable patients to a large degree, that one part of the intervention bundle here was also skin-to-skin care as soon as possible for those infants who were deemed stable after birth. And when we think about this concept of skin-to-skin contact, which obviously has gained much attention, and I think rightfully so, there's a lot of studies I think we all know from Scandinavian region especially, and I just picked one out, which was a randomized clinical trial targeting very preterm infants. And you can easily see on the bottom of my screen the gestational age of the both cohorts was actually around 30 weeks of gestation, and with birth weights around 1,400 grams. And let's first look at the exclusion criteria, which I think is something that is very important. And not very surprisingly, those preterm infants who required more respiratory support, like needing intubation after birth and mechanical ventilation, or those who were rather unstable, requiring high amounts of expired oxygen, those were excluded or not randomized. But if those very preterm infants were actually deemed rather stable, most of them were on CPAP, they were randomized either to receiving skin-to-skin care with mom or dad, or standard care, which was care in incubator and transferred to the NICU in this incubator. And very nicely, and I think that is very encouraging actually when you think about this concept of skin-to-skin care rather immediately after birth, we can easily see that there was no difference in the incidence of hypothermia, which in this study was defined as a temperature of below 36.0 degrees of Celsius within 2 hours after birth. And we can also appreciate that these hypothermia rates were rather low when you think about 4% in comparison to 7%. I think that's actually remarkable. What is also remarkable in this study, and I've marked it here with this red bar, is actually that the rate of hyperthermia, which means or was defined as a body temperature above 37.5 degrees of Celsius, again within 2 hours after birth, was significantly higher in the group who received standard care in comparison to skin care after birth. So we could summarize based on this singular randomized clinical trial that for this cohort of very preterm infants, skin care was actually safer in terms of maintaining normothermia after birth. And also it was safer because some events of additional hyperthermia could be avoided by placing those rather stable infants skin to skin with their parents rather immediately after birth. And I found it very remarkable, actually, that the French Neonatal Society, in their clinical guidelines on optimizing homeothermy in neonates, actually put it like that. Yeah, I think we will all agree that skin-to-skin contact is rather easy to facilitate, and it's, if you want to start implementing a thermoregulatory intervention bundle, it's rather easy to implement actually when you have the right mindset in place. Yeah. I think would also agree that placing infants in direct skin-to-skin contact with mom or dad, it's not only easy, it's also rather effective. But I found it very striking and very remarkable in a positive way that the French Neonatal Society actually called skin-to-skin contact in preterm neonates the first-line treatment for preventing mild hypothermia, but also for correcting mild hypothermia. And this, I think, is something that has not been studied extensively, because I think a lot of studies are actually targeting admission hypothermia and how to actually prevent admission hypo or hypothermia, but there has been just little evidence thinking about if mild hypothermia is actually happening or has already happened, what can we actually do and what is the best and most effective way to correct hypothermia in those infants. And this actually leads me to a session which I've put quite some thought in because I had some difficulties just deciding which knowledge gap I actually would like to discuss and present to you. But I've come up with this selection. So first and foremost, I think every one of us agrees that postnatal hypothermia and also hypothermia is detrimental when we think about the outcome of our babies after birth. Fine. We know that the HWO recommends normothermia within the range of 36.5 to 37.5 degrees of Celsius. And most of the studies actually target an area of body temperature like that. But actually, when we think about and read some of the literature, there's different suggestions and even different targets when we are specific about that. I've just put these three in here. When we start on the left, again, it's the study by Amanda Winkler and colleagues, which are presented with the hypothermia quality improvement bundle. Yeah, what their goal was to keep babies within this normothermic range as defined by the HWO. Another study presented in the middle here with the abstract, those colleagues, they targeted a little bit broader range, yeah, of 36 to 38 degrees of Celsius. There was no clear reason for that. Could be that it's easier for us clinicians actually to get on point here. And when we again think about the clinical guideline by the French Neonatal Society, yeah, there's a recommendation that we should have a target of 37.0 degrees of Celsius, not only for postnatal stabilization, but also for the care of the infants in the NICU. So you see, different studies targeted different temperature ranges. And of course, that makes the comparison between studies a little bit more challenging. Yeah, and actually, I cannot give you a real clear recommendation of what range to target. Yeah, but I think that's a very, very important topic for further discussion and thought. Again, when we look at old literature, and I've found one study actually from 1984, yeah, where I found a very interesting definition of the so-called thermal neutral zone or neutral temperature. Yeah, the colleagues around Sauer and friends defined this neutral temperature as an ambient room temperature at which the infant's core temperature is between 36.7 and 37.3 degrees of Celsius, and the difference or the change of core and mean skin temperatures are below 0.3 degrees of Celsius per hour. And I think that sounds, at least to me, like a very physiological definition of neutral temperature for actually every infant, not only for those in this study who were of very low birth weights. But of course, you can easily see out of this quotation on the right what the colleagues in this study setting actually did. They measured temperature at different areas of the skin, like forehead, left hand, left upper arm, abdomen, thigh, and left foot, but also rather invasively with a sensor placed at mid-esophagus level. And what they came up with out of this study was a definition of those ambient room temperature, which actually contributed to this thermal neutral or neutral temperature zone in very low birth weight infants. And you can clearly see how high these values are during the first several postnatal days after birth. Yeah, starting with 36.5 and slowly decreasing after 1 week of postnatal life to still 33.5 degrees of Celsius of ambient room temperature, which would be required. And of course, room could also be incubator to keep very low birth weight infants at the neutral temperature. This brings me again to another very important and I think very discussion intensive topic, because when we all think and remind ourselves, where do we actually measure body temperature in preterm infants? Yeah, and I brought you here with one rather new international survey, surveying different areas of the world in terms of different practices during postnatal stabilization. And of course, it picked out here where body temperature, or actually they asked for skin temperature, was actually placed during resuscitation or postnatal stabilization. And I think you can easily see that the majority of those surveyed institutions, and it was more than 800 institutions from several continents around the world, the majority of institutions that were surveyed actually placed a skin temperature probe at the front of the abdomen. And then there was, I would say, a divide between axillary measurements and skin temperature measurements on the back. Very interestingly, in this survey, they didn't even ask for, like, for example, rectal body temperature measurements. Yeah, they clearly asked for skin temperature probe placement at resuscitation. And please keep in mind that the majority actually measured the skin temperature at the abdominal wall. And there's just very little association studies between different temperature measurement locations. One coming from Lisa McCarthy and their colleagues from Dublin, who actually studied the association between rectal body temperature and axillary body temperature. And I think you can clearly see on this graph that there was a very clear-cut association between those temperatures, between rectal and axillary body temperatures. But when we read the text, which is in the manuscript actually, the colleagues inform us that these individual body temperature measurements, again comparing rectal and axillary body temperature measurements, may vary up to 1 degree of Celsius, which is the whole range of normothermia when we think of the HWO recommendation or definition. And there's also some other studies, like the groundbreaking study from Laptuk and colleagues, who clearly provided us with the information that for every 1 degree of Celsius below normal temperature, the risk of dying will increase by 28%. And in this study, again, including several thousand neonates or preterm neonates, there was a slightly lower discrepancy between rectal and axillary body temperatures, but still, yeah, there was a variation of up to 0.4 degrees of Celsius when comparing rectal, axillary, and body skin temperatures. And if we decided to measure the temperature on the baby's body surface, which means on the skin, and please again remind yourself about the survey results that I presented you just 2 slides ago. Yeah, we have also some data clearly showing us that the positioning or the location where you put the skin sensor on your preterm baby or preterm patient actually significantly impacts the results of body temperature measurements that you will get. And in this study by Hyman and colleagues using thermography after birth, yeah, you can clearly see when you look at those black bars that the temperature which is being measured on the baby's back is around 1 degree of Celsius lower in comparison to a skin sensor on the upper abdomen. So with high variation between skin temperature measurements and axillary and rectal temperature measurements, which are more closely associated. And when we do skin temperature measurements in our preterm babies, it's very, very important, probably to be consistent. And we should clearly think about these differences just when we think about, do we place the sensor on the baby's back or on the baby's abdomen? And even if you have decided on the body location where to measure a baby's body temperature, of course, we all know that there are different monitoring devices. Some, of course, are very cost effective, like human touch, which of course has a lot of disadvantages, or rather old thermometers like the mercury glass thermometers. And of course, there's then less invasive or even contact-free measurement methods. Although, like for example, the tympanic thermometer, there's no tool available for preterm neonates as of right now. And I think one of the gold standards probably will be electronic thermometers like this one is shown in this systematic review. And again, depending on which device you use, so not only depending on the location where you measure, but also depending on which device you use, you may get some differences in results, yeah, regarding body temperature. Yeah, and again, the group around Emma Dunn and colleagues from Dublin did a very important work, actually telling us that if you use certain devices, yeah, there may again be a variation in body temperatures being measured of 0.4 to even up to 0.6 degrees of Celsius. And when you add that up to those differences that I just showed you in regards to body temperature measurement location, yeah, we can clearly agree that the numbers that we get are probably not the correct numbers in terms of core body temperature. The next knowledge gap that I would just briefly mention, and I think that is probably one of the knowledge gaps with the least amount of evidence upon, is actually what the impact of our own medical or postnatal care intervention is on our patients' thermoregulatory efforts. And I found this study, and it was a very small cohort of only 12 very premature babies, yeah, where the impact of different respiratory care interventions was studied on baby's body temperature. And there were two main outcomes out of this very small cohort, actually. The first one was that mechanical ventilation, but also CPAP, were associated with lower body temperatures. And very interesting also that those infants who received CPAP, yeah, comparing to those who were in need of mechanical ventilations, had the highest risk of suffering from hypothermia. And again, I think it's always an issue with all of these association studies. We can not be sure if mechanical ventilation and especially CPAP actually contributed to those lower body temperatures, or if that is just a sign of those babies being more unstable, requiring either CPAP or mechanical ventilation, and that being the reason for their tendency towards lower body temperatures. But I think this is very important, actually, that we remind ourselves not only does the measurement have a significant impact on the results of body temperature, but also all of the interventions which are not primarily dedicated to stabilizing thermoregulation and neonatal body temperature after birth may have an effect. And the fourth knowledge gap that I would address here in this audience is this concept of admission temperature. And there have been some definition of and recommendations, actually, that's one from ILCOR, clearly telling us that within 60 minutes after birth, or at the latest at admission to the neonatal intensive care unit, we should record at least one single value of body temperature. And you can clearly here see also the terminology related to hypothermia, cold stress or mild hypothermia below 36.5 degrees of Celsius, and then moderate and severe hypothermia. But when we think about the concept of admission hypo and hypothermia, or admission temperature in general, I think the first thing that comes to everyone's mind is actually, when is the admission temperature being recorded? And again, I just brought up two definitions out of the studies that I previously showed you. Yeah, the first one being this large study from Liu with the almost 10,000 preterm neonates, yeah, where the definition of admission temperature was just during the first hour of admission to NICU. And actually, they did not even provide us with the minutes after birth when those values were actually being recorded or being taken. In the study from LabTook, which I briefly showed to you before, there at least is a number of 23 plus minus 40 minutes at which admission temperature was being recorded in those preterm infants that they studied there. So I think the one issue, or at least the one issue that I have with the concept of admission temperature, we clearly know, and I've clearly shown you all those huge studies with large cohorts showing that admission hypothermia and hypothermia is associated with negative outcomes. And we can completely agree on that. But I think it's very important when admission temperature is actually being recorded. And there will always be the question, I think, especially if admission temperature is, like, for example, recorded during or between 30 and 60 minutes after birth, there will always be the question, is the singular body temperature value more reflective of our interventions and our practices, or is it more reflective of the unstable condition of the patients that you treat? So I think, and that would probably be one of my topics of the research agenda, I at least stress that measuring one value probably does not give you or give us the whole picture. And I think that is at least something that we have to agree upon. I also promised you that I would like to address one challenge next to all the knowledge gaps that I tried to summarize. And I think one of the major challenges that we have in all of neonatal care, especially during postnatal care, is actually the critical time of neonatal transport, especially if it's neonatal transport immediately after birth, when the delivery room is not directly next to the NICU. And I think next to all the other management issues that we have to preserve during neonatal or postnatal transport, keeping babies warm after birth is a significant challenge, not only in the delivery room, which is a rather stable concept and surrounding, but also, of course, during the critical period of postnatal transport. And again, data from the cohort or the colleagues in Dublin who provided us with some data of the temperature development in very preterm infants from birth and delivery room stabilization to departure from delivery room to admission to the NICU. And I think we can clearly see here that temperature on arrival, which was after delayed cord clamping, was very well within the range, at least on the mean. Temperature at departure was a little bit lower, which was 17 minutes later on average. And again, it dropped, and we can all agree that this is not a significant drop, but it clearly shows, yeah, that even if we do our best, and for example, the transport here was done in a pre-warmed incubator. So even if we do our best and have a clear focus, like in this study, on temperature development over the first hour after birth, there will be a significant number of infants who still will get hypothermic. And when we think or appreciate here the percentage or the incidence of very preterm infants being hypothermic, starting with 27% after birth, rising to 37% after delivery room stabilization and before departure, and again rising to more than 50% at admission to the NICU. I think we have the conclusive data showing that neonatal and especially postnatal transport is a danger when we think about keeping babies warm and well after birth. And of course, there will be a lot of different interventions. I've touched upon this topic of bundle interventions a little bit before, aiming to keep neonates warm after birth. And I've just picked here one study, which was a multi-center cohort study in China, where 20 different interventions were actually combined to different bundles, all with the aim to decreasing admission hypothermia in this cohort of very low birth weight newborns. And it just, again, because I wanted to stress the issue of the postnatal transport, I just marked here in green, yeah, like for example, bundle intervention 5, using a heated transport incubator, which is plugged in, switched on, and set to a target range before actual birth of the premature infant. And again, also start transportation only when the incubator is available, when the incubator was being preheated, and using that preheated transport incubator to safely and hopefully warm enough bring the babies to their NICU. But, and I think it's also something that a lot of us have already experienced when we do quality improvement projects, especially when they are split out over a certain time frame, there will always be some backslashes. And I think this is clearly shown here in this study again, because when you look at the PDSA cycle 2, which ranged around 3 months in this study, yeah, PDSA cycle 2 consisted of this preheated transport incubator, which should be readily provided before transporting the infant to the neonatal intensive care unit. And I think when we look here at this line with AH, standing for admission hypothermia, first, we must clearly acknowledge this strikingly high percentage of admission hypothermia in the pre-quality improvement phase. Yeah, 96% of those babies in this pre-implementation phase were hypothermic at birth. So this is a drastic and dramatic number, and that is probably the main reason why the colleagues decided that they had to change something. And then you can easily see over those first intervention phases, yeah, that this number is significantly dropping, which of course is a good sign, to 75%, then again to below 70%. And then there's this PDSA cycle 2 with the preheated transport incubator. And then you see a striking increase in admission hypothermia again, from 69.6 to 78.1 degree of Celsius, percent. And again, also with the next PDSA implementation bundle, yeah, there's also again a slight increase in the incidence of admission hypothermia before finally the admission hypothermia reaches its lowest point, which of course is a very promising sign. And when you ask yourself, what did happen actually during this PDSA cycle 4? Actually, it was implementation science, like teaching and training all the healthcare professionals, not only about how to do certain interventions, how to use the preheated transfer incubator, for example, but also providing them with knowledge and insight why it is so important to keep especially premature and unstable neonates warm after birth. And I think that's a very clear and very nice sign. If you want to improve upon your practices, always consider the concept of implementation science. Yeah, it will not be enough to come up with a lot of clever and evidence-based recommendations and interventions. You must make sure that every one of your staff is aligned towards a common goal of keeping babies warm after birth. And I think then the cycle is being closed, and all of your interventions that you combined in your bundle or quality improvement project, they hopefully will work as you planned out. And I think when you think about the concept of keeping babies warm after birth, there will always be certain interruptions. Yeah, like for example, and we saw that in the data from Emma Dunn and colleagues from Dublin. Yeah, babies were rather warm when they were being brought to the resuscitation table or incubator. They lost some heat during the process of postnatal stabilization, and then again they lost some heat when they were being transported to the NICU. And of course, we can never be sure what the reason actually was, but we know from several studies that if you stabilize, especially a very immature preterm neonate on a resuscitation table, for example, and then you transfer them to a preheated incubator, this alone may render them susceptible and vulnerable to suffer from hypothermia. And again, it would need then the preheated incubator to rewarm the baby. And of course, there's different concepts, and this is just a concept that we use at my institution in Graz as well. Either we do physiological-based cord clamping, which has always the issue of when we drive out of the delivery room or the C-section room with the baby on our Concord trolley, of course, there will always be the need to transfer the baby from the Concord trolley in a preheated incubator. But if the baby is for whatever reason being stabilized in an incubator after birth, and if the baby for whatever reason needs to be transferred postnatally after birth, then concepts like this one with a shuttle solution providing you with respiratory care, with infusion pumps, could actually add to thermal regulation and help you as practicing clinicians to support your baby in keeping them warm after birth. And I think this concept of the mobile NICU is just something that we need to think about, because it's a progress. Like, for example, starting with birth, during postnatal stabilization, many institutions need to, after stabilization, transfer the patient to the NICU, which in many institutions is not next to the delivery room. And I think this is where this concept of a mobile NICU, which is being provided immediately after birth, has some added benefit and value. And I think that it's just something that we also need to interact with our technology partners to get the best technology available to maintain normothermia in all of our patients. And with that in mind, I would like to sum up my key areas for future research, especially based on those knowledge gaps that I previously discussed and presented to you. I think we would definitely require to get different prospective studies comparing different temperature targets for premature infants during postnatal stabilization after birth. That would be very helpful actually for us as practicing clinicians and neonatologists to know, is it 36.5 degrees of Celsius, or should we aim higher, for example, to get more of our patients in this normothermic range? Then again, I think measurement is crucial, because if you just have one value, that could be nice, but where actually was this one value being measured? Was it skin? And where on the skin was the value actually being taken? Was it axilla or was it rectum, which could be more of a core body temperature? Yeah, I think that is something that we need more data on, especially comparing the predictive value of these different body temperature locations and measurements. Then We also need to compare in study settings different thermometers in clinical settings, because the study from Lisa McCarthy and colleagues that I showed you previously, that was used or actually performed in laboratory setting. So of course, we always need to prove, do these differences that were being shown there and which were striking actually also contribute different values in a clinical setting. So I think we would also require a prospective comparison of different measurement devices. But of course, what we would also love, especially as neonatologists, always aiming for more non-invasive measurement and monitoring devices, we should also call for development and investigation of novel non-invasive temperature management devices. Also, we must better understand what the effect and impact of our postnatal care practices, for example, like stabilization of cardiocirculation, has actually on thermoregulation and body temperature management. I think that would be crucial not only to stabilize patients, but also to be able to consider if certain interventions, like the respiratory interventions that I briefly showed you, have an effect on our baby's thermoregulation. And finally, and it's just something that I'm thinking a lot about, I'm just currently planning a study on that. I think, again, critically assessing this concept of admission temperature, yeah, we should get more evidence and ask ourselves, is there maybe an added benefit if we measured continuously postnatal temperature in comparison to measuring admission temperature once during the first hour after birth? And I think all of these key areas for future research, and there's certainly many more, all of these would contribute us helping our patients more and more to be and to stay warm after birth. And with that in mind, I thank you very, very much for your kind attention. I'm looking forward to your questions and hopefully to a lively discussion. Thank you very much.
Thank you so much, Lucas, for the fascinating session again. And to remind the audience as well, don't forget that we do have the Q&A function there down at the app that you're able to post your questions or comments, and also some discussions about how you keep your babies warm there in your unit. Is there any practice that Dr. Lucas has shared has also been the practice in your unit? Something's working, something's not, or something that you may think has overlooked or anything. Everything is welcomed to have a live discussion here, since we have the privilege to have Lucas with us. And while we're waiting for the questions, so far I don't see anything. First of all, I think it's crystal clear, and I think from my side as well. And I think it's another great session as usual. And it's always like surprised to know like how many babies are still admitted cold there in NICU. Every time I see the number, it's always astonishing, because right now that we've been discussing and also studying for years about how to keep babies warm, but still, of course, there are still things that we're not able to perfection, like all the practices and doing the whole journey, right? And it's also very, very important for these kind of webinars and also the study progresses for us to discuss with each other what can be the different definition or different understanding of certain things. For instance, like what you have mentioned, which body temperature to targets. Maybe sometimes we will not be thinking about it. We know that there are studies, there are data showing there, saying, okay, so this should be the target temperature. However, have we also think it through, like for different scenarios or for different kind of baby? Do we need to target different body temperature, and where to measure as well, right? And does like admission temperature, yes, it values, and how do we, like when to really measure the temperature would be the admission temperature. So everything is really interesting, and to really bring it up to the table and for people to rethink and to look at what you have been doing there, doing your practices, and also don't miss out the very important intra-hospital transportation process as well. While baby is on the way, is the temperature management also being looked after? or if there's anything that we can do better during the whole journey for the neonates. So with that being said, anyone who would like to, or like you can raise your hand if you want to have a live discussion. We have the final 3 minutes that we can have maybe 1 or 2 questions to answer. Or any last words from you, Lucas?
Well, I think you summarized some of the topics and some of the things that drive me actually around this topic very well. I think I just want to share one of my own experience actually. When I started doing neonatal care, actually body temperature was just something that I thought that I had to record. And of course, if it was outside of normal range, of course, we did something around, like for example, in the incubator, we increased the temperature or we increased the humidity. So of course, there was always awareness, but actually, when I started doing neonatal care, it was just one value out of many values. And of course, like oxygen saturation, heart rate, even blood pressure, I always had the impression initially in my career that they were more important. Yeah. And the more I've read about, and we all know that, like, for example, heart rate and cardiocirculatory function is so closely interrelated with respiration and oxygenation. And I think somewhere in that, body temperature, of course, has a significant impact. Yeah. And I think we would have better normothermia ranges if we acknowledge that it's not just one value that you have to measure because it's required to record, but really attracting attention and guiding our attention to the topic. I think that's a very, very important first step. Besides all the intervention, some of them easy, some of them more difficult, some of them more technology prone, others very easy, like putting a stable baby on mother's or father's chest. I think that would be a very, very first important step, guiding our attention towards this is important, not just a value that we want to measure.
Exactly. As we all know, it seems like a basic topic that we all know, like temperature is important for babies. Therefore, it's easy to neglect as well at the same time. So yes, this is very important for us to bring this topic back to the table over and over again and really look at what we're doing and if there's anything we can do better to have better outcome for all the neonates and the little ones. Great. So I think this is very clear, and thank you all very much to stay with us until the end. So we will share this webinar with you also online, and I believe that you have seen where to look for Mr. Lucas Milter as well, if you have any further questions or discussion point that you want to talk about with him or us. So feel free to reach out, and I wish you all have a good day or good... Oh, sorry. I just have one question pops up actually in the very last minute. Let me read it through. So, when moving from radiant heat with the canopy open to incubator mode, the set baby temperature is often set to 36.8, which does not allow for temperature drops while the incubator heats up to the required comfort zone based on the baby's state of life, gestation, and weight. I found in my own practice, setting the baby's skin temp to 37.3 allows for some heat loss and keeps the baby within a thermothermic range while the incubator warms up to the desired humidity and temperature for that baby. What does your unit set the baby's skin temp to prior to closing to the canopy? And do you have any episodes of hypothermia during this process?
I think that's a wonderful question. It's a very difficult one to answer because there's different aspects that we should actually think about. So the first thing, of course, is also in my institution, we always try to preheat the incubator to 37.0 degrees of Celsius. The next thing, and it's also very interesting, and like I said, there's so many different ways to do thermal care. Like, for example, in my institution, we measure temperature rectally and not in the skin, with the argument that rectal temperature is more narrow to the baby's core. Yeah, but I also know that there are some regions in the world, like Scandinavia, where rectal temperature measurement is actually not convenient. Yeah, so again, there's another difference in practices. Yeah, and I think that's just two of the aspects. The third aspect could actually be, and I think that's probably also within this question, is do we use servo control or not? Yeah, We in my institutions, for different reasons, we set the temperatures manually, which means our nurses set the the incubator temperature up and down, depending on the baby's temperature, which is being measured rectally. But we also know, and I think it's almost a 50-50 divide between institutions. Around half of institutions in international surveys, they use servo control. Yeah, and I think that is just some of the variables that we have to consider. So I'm afraid that I cannot sufficiently answer the question, because there's just some differences in practices between my institution and yours. But I think that's also very stimulating when we think about what's the actually gold standard. And I wouldn't even be able to tell you what the gold standard is. I think a gold standard is just some standard that works for the babies at some institution. And again, I think it starts and ends with awareness and really being consistent in measuring and also addressing issues around hypo and hypothermia.
Great. Thank you, Lucas. Hope this answers your question, and feel free to reach out to him as well if you would like to have a further discussion. So awesome. Thank you all. I know that we're a little bit out of time, but that's definitely worth it. Thank you again, Lucas, and thank you all, and looking forward to the next one. Have a great day.